Can everyone hear me? Awesome. Okay, so I just have a quick little review for chapter 24, which is the hematological diseases. So I'll get started. So chapter 24 is hematological dysfunction. So assessment of hematological function. So there are many ways that we can actually assess if everything is the way it should be. The first one is going to be complete blood count, or a CBC. This will be checking the hemoglobin, the platelets, the hematocrit. Next, we would check historical data, so dietary recall over the last 3 days. And then if you need a more specific one, you can go for a 7 to 10 day recall. We'll also look at a physical assessment finding. So is there bruising and bleeding? What's the extended period of time of bleeding? Is it easy for them to clot? Is it not easy for them to clot? Do they bleed when they're brushing their teeth? And how is their activity level and their cold intolerance level? Like, are they okay being in a cold room, or is it something that's far more painful for them than their significant other or their parent or whoever? Child's energy and activity level. So the faster the heart rate, the more bleeding can occur. How quickly do they tire? And again, are they getting cold easily? Are they the kid that gets cold fastest in class and always has to put on their sweater? Are they the child that the parent has to pack a sweater or a sweatshirt with to school, even when it's June? So these are important questions to be asking the child caregiver or the child if the child is old enough to answer. So anemia, it always does this thing where sometimes it just won't convert my slides over. It makes them black when I have them white, and then the typing is black, and then we have a slide like this. So give me 1 second, and I'll pull up the slide so I can read it to you guys. Okay, so anemia is the most common hematological disorder in children. It's a decrease in the number of red blood cells and or a hemoglobin that's less than normal. This is the case if it's a decrease in the number of red blood cells, and there's a decrease in the oxygen carrying capacity of the blood that leads to a shortage in the amount of oxygen available to the tissue. And when anemia develops slowly, a child will actually start to adapt. So they might not have a lot of the symptoms of anemia that we are trained to see right away because the body has been slowly adapting over time. They may not complain about being tired because they're just so used to feeling that way. So I was a kid who had a lot of low blood cell counts and a lot of low hemoglobin growing up, and I just always thought it was normal to feel tired. So I never complained about it to my mom. It wasn't until I actually, started getting iron again and everything that I needed that I realized that kids aren't supposed to be as tired as I used to be. So, but if you don't know any better, if this is something your body has adapted to, they're not going to complain to the mom or dad about it. And that's why it's important to be taking these tests and encouraging children to go for their physicals every year to make sure that everything is okay. So some clinical manifestations when this is occurring, when there is anemia, would be the child's a little bit more pale. They will have a higher heart rate than their age range, and they can also have a murmur. They'll have dry hair and skin with brittle nails. They can have an increased capillary refill time, and they'll feel fatigued, whether or not they recognize that fatigue. Diagnosis, so complete blood count, you're going to see a decrease in red blood cells, a decrease in the hemoglobin level, less than 10 or 11, and a decrease in hematocrit. There also will be further testing to determine the particular type of anemia that's occurring for the child. So it's important to educate mom on your child has anemia, why we're doing further testing, what possibilities there are for the cause of anemia. And then once we figure out what is causing the anemia, educating mom on how to prevent the anemia from being as bad as it is that brought the child in. Treatment, so you're going to treat the underlying cause, whatever it is that is causing the child to be anemic, and supportive care. Your nursing considerations are going to be prep the patient and the family for lab tests. So tell them what's going to happen, let the patient know how it's going to feel. We always want to be honest with our patients, no matter how young they are. And we always want to be honest in a way that they will understand. And then you're going to go through with mom and dad or caregiver everything that they're going to be doing. You want to cluster care in these patients because they do tire easily. So you don't want to keep going in there every hour with something new for them to do. If you can do everything at once and allow them an extended period of rest before the next time you come in there, that'll be best for them for their healing environment. You want to prevent complications. So you want to get ahead of any complications, the type of anemia that they have may cause. And that is done a lot through educating parents. And then you want to always support and educate the family. Okay, this one came through okay. So iron deficiency anemia. This is caused by an inadequate supply of dietary iron. Generally, this is very preventable. You can catch it in well-child visits as long as mom and dad are constantly bringing in little Timmy at a regular basis. You want to keep the diet adequate with iron. Premature babies are at higher risk, and adolescents, because of their growth demands, menstruations, and poor eating habits and fad diets, are also very much at risk for iron deficiency anemia. It's predictable at developmental periods, so we know that premature infants, because it's due to the low fetal supply that they've received, so you know that to watch your preemies for iron deficient anemia. Around the 12 to 36 month mark, they can also become iron deficient, and this is due to ingestion of a large amount of cow's milk. So we always give babies milk because we want them to have their calcium, but milk is not rich in iron, so they need everything in the diet to get the needed amount. So since milk isn't rich in iron, but it is very filling, you want to teach mom to not just give bottles and bottles of milk, because baby will be full, but baby will not have iron. And then adolescents, due to the rapid growth, as mentioned before, and poor eating habits in the beginning of menstruation for females. Treatment-wise, so for infants, you can do iron as a liquid. It'll come in a dropper. You always want to get it past the teeth because iron drops stain teeth. And then after you've given it, so you'll probably give it towards the back pocket of the cheek. So it kind of just washes down as the baby starts to salivate. You'll take a washcloth and wipe the teeth after, just to make sure that any of the iron that's still left in the mouth doesn't stain the teeth. And you don't ever want to put it in a bottle because you want to know how much they got unless they finish the entire bottle. So say little Johnny needs to have 3 drops of iron at every meal or around every meal time. If you put it in his bottle and then he only drinks half of his bottle, you don't know if he got all 3 drops in those sibs, if he actually got 1.5 drops because half the bottle's left, or if he got nothing. So you want to make sure that you're giving it in a proper way that mom knows will measure it. So teach mom, not in the bottle, in the dropper, behind the teeth. And then dietary versus iron supplements. So it depends on the dietary history. Maybe this is just a family that doesn't eat a lot of spinach and they just need to have some spinach with some lemon squeezed on it, and that's it, if it's not that severe. But if it is a more severe issue and iron is something that seems very prevalent in the child's diet, then we're going to look into more like iron pills or iron supplementation of some kind, like the drops. Nursing consideration, just remember that iron does stain teeth, so you want to make sure you give it properly. And you want to educate about the side effects of giving iron, such as constipation, dark green stools, and if you take it, it should be taken on an empty stomach with vitamin C. So vitamin C helps to absorb iron. It helps the body get all the benefits of it. So taking it with a little bit of orange juice isn't a bad idea. If you take it on an empty stomach, it's also far more likely to be absorbed better. Iron can cause some nausea, so it's okay to take it with food to prevent the nausea, because then you don't want the flip side of the child then being too nauseous to eat at all. So you kind of pick and choose your battles with iron. Whatever the best way to get it into the child is the route to go. But in an ideal world, it would be given on an empty stomach. Okay, the next one is sickle cell anemia. So sickle cell anemia is one of the big hot topics that they love to throw on the NCLEX for pediatric questions. It's like that and cystic fibrosis are like the new trending ones to know. So sickle cell anemia, this is hereditary. The testing is not definitive until about 6 months old, though. It's partial or complete replacement of normal hemoglobin with an abnormal hemoglobin S. It's like the hemoglobins, instead of looking like a nice little boat for all the red blood cells to sit on, actually are cyclic. And it's known as hemoglobin S, and it's a sickle-shaped red blood cell. It leads to capillary obstruction because they don't just flow very nicely through the blood vessels due to that cyclical shape. So this can lead to engorgement and tissue ischemia. And this hypoxia that it causes can lead to pain. It is a very, very painful process for a child to have the obstruction. So prognosis, there is no cure, unfortunately, for sickle cell anemia. It's just supportive care and prevention of episodes. Diagnosed through genetic testing. Management, so you're going to prevent, your aim is to prevent the sickling phenomena. So you treat medical emergencies with hydration and pain management, and then we prevent with things like childhood vaccinations and aggressive treatment of any infection, so that a small infection of like strep throat or something that little Timmy's just going to pick up off of circle time during kindergarten anyways isn't going to lead to a sickle cell episode. Medical management, so you want to monitor the reticulocyte count to evaluate bone marrow function, blood transfusions as needed, and eventually it may be bad enough that they'll need a splenectomy. Nursing management, you want to monitor growth and development. You want to do careful multi-systems assessments to make sure no organs are being damaged from the sickling of the cells. You want to assess and treat any pain the child is having. Observe for presence of inflammatory or possible infection. Monitor for signs and symptoms of shock when they are in an episode, and do what you can to promote normal growth and development for the child. In a sickle cell crisis, so this is caused by infection or stress. So the child is undergoing like a lot of stress. Maybe there's a big exam coming up. Maybe mom and dad are going through a rough patch and they're separated. Or it could be infection, something as simple as an ear infection or strep throat. And these things lead to a sickle cell crisis. So some precipitating factors: anything that increases the body's needs for oxygen and alters transportation of oxygen, trauma, fever, infection, physical, emotional stress, and increased blood viscosity due to dehydration and hypoxia. So there's a couple types of sickle cell crisis. There's vaso-occlusive thrombotic. So this is the most common and it is very painful. It leads to ischemia and infarct. There's splenic sequestration, which is life-threatening. Death can occur within hours. This is because the spleen could rupture. So blood tends to pool in the spleen during this, and signs that's occurring is a profound anemia, hypovolemia, and shock. And finally, there's aplastic crisis. This is diminished production and increased destruction of red blood cells. It's triggered by a viral infection or depletion of folic acid. So it could begin to make the body will begin to not make enough red blood cells to survive. And signs include profound anemia and pallor. Okay, finally, there's hemophilia. This is a hereditary bleeding disorder due to an issue within the clotting factors. It is usually X-linked. Clinical manifestations include bleeding tendencies ranging from mild to severe, hemarthrosis, which is bleeding into the joint spaces of the knee, ankle, or elbow, that leads to impaired mobility and eventually bony changes and disability. Symptoms: the area will be warm, pain, there'll be bruising and decreased moving at that joint. They'll have epistaxis, bleeding in the GI tract. This will be with dark, tarry stool. Bleeding after procedures, and bleeding into the neck, chest, or mouth may compromise the airway. So diagnosis is through an amniocentesis. After birth, it can be genetic testing, and it's going to be kind of based on Oh, can we just make sure everyone's muted? Okay, so it's going to be based on the history, lab work, and an examination. So management, so replace missing clotting factors. There's also going to be a treatment with desmopressin or DDAVP. Transfusion for major bleeds. They're not going to be allowed to be in contact sports. So when in doubt, if there's a question about how would you promote growth and development in a 7-year-old boy who suffers from hemophilia, who wants to start doing sports, what sport would be appropriate for the child? When in doubt, pick, swimming. That is the go-to. Swimming. Sometimes golf gets tossed in there, but swimming is usually the go-to for any sport for little Timmy who can't participate in contact sports for some reason. And then you always want to have them wear protective equipment, especially if they're riding a bike or doing something like that. Prognosis, so patients with mild to moderate hemophilia will live nearly normal lives. Nursing care, so you want to prevent bleeding episodes. Make sure your patient is safe and is not at risk for anything that could cause them to injure themselves. You want to recognize and control bleeding early. Use RICEs for blunt injury, so that's the rest, ice, compress, elevate, support. And then support the patient, whether it's supportive for pain measurements, mobility, and what you can do to promote growth and development, like recommending swimming. And support the family, education, and prep for home care. So it is especially important to educate the child's caregivers on how to spot bleeding just like you would and how to control that bleeding fast. You also want to teach them the ways that they can help promote growth and development, like signing little Timmy up for swimming, and other things they can do to help him to lead as normal of a life as possible, because we don't want them to coddle him too much and prevent him from having a normal life, but we also don't want them to just allow him to run free with no bike helmet or to join football. So intervention, close supervision, and safe environment. You want dental procedures in a controlled situation. Have them only shave with an electric razor. For superficial bleeding, you're going to apply pressure for at least 15 minutes and ice to promote vasoconstriction. If it's significant bleeding, there's going to be transfusions for replacement. And you want to prevent obesity as this puts a lot of physical stress and pressure on the body. Okay, so that's all I actually have for this chapter. This chapter isn't very long. Do you guys have any questions for me on this stuff or any stuff in pediatrics? Yes, so the main goal is going to be to keep the child safe at this point and get the bleeding under control. And then we would monitor for any signs of blood loss or if hemarthrosis occurred, depending on the location of the bleed. No problem. I would definitely teach ahead to a parent like that, just that way they know that these things do. I don't want to say they're common in people with hemophilia or children with hemophilia, but that way, if it were to be something that would be needed, you would have already kind of started to pre-teach them about it and prepare them for it. So they know like what the worst case scenario treatments are going to be. And it also kind of helps to reiterate like the importance of spotting bleeding and putting pressure on it as soon as possible with ice even if it's just a small little like knee skid, you don't want to have to end up in the hospital where we may have to do a transfusion. So it kind of, I think, would help not scare them into it, but like educate them to like what we're trying to prevent is probably a better way of putting it. Yeah, anemia can affect growth and development in many ways, especially with the fatigue. They're not going to be out running around with kids their age. They may not feel up to joining like a lot of the same activities that their friends do. And then it also depends on what kind of anemia they have. If they have sickle cell anemia, these children spend a lot of time in the hospital. So that really hurts their ability to create these social bonds that someone their age usually does. I know when I had my clinical rotation at St. Peter's, there was a little boy that knew every single nurse's name. He had favorite nurses, and he was in for another sickle cell crisis, and he never even stayed in his room. He just hung out at the nurse's station all the time. I think he was like 7 or 8, because his mom had other kids at home, so she had to be home, and she also was working. So he just was like, he had the run of the entire floor because he knew the nurses. And at this point, he probably knew the nurses better than he knew his own schoolmates, which affects his ability to socially evolve and grow. No problem. So you would give it on an empty stomach, ideally with something that might have some vitamin C in it, because they're going to need to take like an iron pill with something. So you could take it with like orange juice. That was how Dr. Carew taught us for like adults when they take iron pills, is to have them take it with orange juice so that they get all the vitamin C in the orange juice and the benefit of the iron pill as well. With the drops with the baby, they could just take it on an empty stomach, because I don't think most infants would be drinking orange juice. So it would all just be like what form of iron you're giving it and the age of the patient. But if they're going to eat like something like spinach or strawberries, pairing that with like a lemon chicken would really help to absorb all that iron that's in the spinach. No problem. It does have a big effect on the spleen, and then also you want to prevent infection as much as possible, because any tiny infection creates the sickle cell, can lead to and create a sickle cell crisis, which is very painful and can lead to the loss of the spleen, or depending on what kind of crisis it leads to. But the goal with sickle cell patients is always to create an environment that's going to prevent a crisis from occurring. So if you know that their older sister is sick, you're going to keep them separate from their older sister as much as possible, because you don't want a crisis to occur. You don't even want them to catch what she has. And then even though she might be on a low dose antibiotic for, let's say she has strep throat, if little Timmy, who has sickle cell anemia, catches it, he is going to be on an aggressive amount of antibiotics to prevent that crisis from happening. So there's a lot of like teaching in preventing sickness and illness, and really anything that would cause a crisis. Like I can remember doing a review question that asked like, a patient's family has a 14-year-old with sickle cell anemia, something like that, and they want to go away to like Denver, Colorado to go skiing. What would you do as a nurse? And the answer was, you would tell them like, essentially, don't go. You're going to like really cause a crisis in your daughter from that like high altitude. So it's more just everything is trying to prevent that like sickle cell crisis. I wouldn't say they're immunocompromised, because their body can fight infection. Yeah, it's pretty much we're trying, like you want them to get vaccinated. Whereas somebody who's immunocompromised, you would not want to get vaccinated, but you want their vaccinations on. Yeah, because any little stressor on the body can cause a crisis. Yeah. It may make them more, I'm not 100% sure, it may make them more prone because their body is spitting out incorrect red blood cells. So it's probably more focused on creating red blood cells. Like they're definitely like hematologically off. So I wouldn't be surprised if there is like some correlation with the white blood cell count that would make it harder for them to prevent infection in their own body, which is why it's so important for teaching parents and when they're in the hospital for us to be the ones to prevent them from getting an infection. Yeah, so if you're starting, I think inspiratory croak, the acute like epiglottitis kind of like whole field dynamic, you want to have the trach at the bedside because they're so prone to having like everything flip all over the trachea, like that inflamed epiglottitis flip over the trachea. And at that point, the only thing you could do is put in a trach. So if you think that the child has that, you want to have the trach stuff at the bedside. You're going to do pretty much a minimal assessment of the airway because you're not really going to want to move the child from whatever position they're in. Because as soon as you move them, you risk blocking off the trachea. So if little Timmy has found himself in a position that he can breathe, like keep him there. Oh, no problem. Yeah, it gets like pediatrics gets so confusing because for the most part, you are going to stick to Maslow hierarchy of needs. And when it comes to the NCLEX, that's like the thing to go off of to answer all the questions. But with kids, because they're so tricky and they're so small, there are so many little variables that like tweak what Maslow's hierarchy of needs is for the child. So that's why like I always say do your case studies because the case studies help to teach you how to like what those little variables are going to be and how to like how to train your brain to tweak when you need to like not really go off of the usual priority of Maslow's, if that makes sense. No problem. Any other questions on anything pediatric? Yes. All the reviews get recorded. I believe it starts at 10. Let me just check my, yeah, 10 o'clock. No problem. Your exam is just on respiratory, cardiac, and hematological dysfunction? Just those three, right? Okay. Oh, go ahead. I'm here till 7:30, so ask away. I would know like what makes it unique, like compared to the other stuff. A lot of the same like clinical manifestations are going to be seen between the two, because they're both like an increased pulmonary pressure, or they're, like when you're looking at all the differences, like a lot of the increased pulmonary pressures are going to have a lot of the same clinical manifestations, just like a lot of the decreased pulmonary pressure ones will, and a lot of the obstruction ones will. So a lot of them are similar, which makes it a little bit easier to study, because you can be like, okay, this one's an increased pulmonary one, so I know that these are going to be the general symptoms. But then I would also just kind of from there tack onto and what makes this one different from this one, so that if it's a atrial septal defect specific question, you can kind of work it out in your head a little bit more, to answer it correctly. Because there are like a couple little things that make each one different. So just knowing those couple little things would be what I would focus on. And then just in general, like, okay, for someone who has this increased pulmonary pressure, focus on studying like how you would treat a patient who has that, if that makes sense. A lot of it would have to do with how you would explain it to a child. And also just kind of like seeing where they are in the developmental track, like, what you would be teaching the parents about it as well. Um, but overall, it's like, I think overall, most of the treatments are the same. There are a couple where it's you do palliative until they're a certain age when you can actually do a full surgery to correct and repair. So knowing kind of that helps, like at what age they actually can then be treated with the full repair and no longer just palliative to allow them to live long enough to have that surgery, would be important. But yeah, I'd say like overall growth and development is just more to like how do you get them to do the treatment? How do you explain the treatments to them? How do you advise mom? What do you have to watch for in that age group? Because what you have to watch for with like a 12-year-old with asthma and how you teach them versus like a 16-year-old that doesn't want to be the same as her peers, or wants to be the same as her peers and doesn't want to be different. There's going to be a lot of different things you look for, um, and gear your time towards when you're with the patient based off their age. Essentially, I mean, you don't want to think of it like congestive heart failure because it's not technically congestive heart failure, but a lot of the same symptoms kind of apply. So your increased pulmonary pressure diseases have a lot of the same clinical manifestations as what Dr. Carew taught you as for left-sided heart failure. And it's because you're getting so much of that blood stuck in the lungs. So you're going to hear those crackles, and then there's a decrease in the O2 because it's trapped in the lungs. So you're getting this enriched oxygen that can't get back into the heart and out to the body. And then with it being more like systemic with the decreased pulmonary pressure, it's mimics a lot of the right-sided heart failure symptoms, even though it is not heart failure that's causing it. It just happens that it's creating like backup that because that blood can't get into the lungs. So you're seeing a lot of those things backing up into the system. And getting stuck more in that right side of the heart, if that makes sense. You're welcome. Any other Peds or level 3 questions like OB or adult health, or anyone's having any difficulties in trends? I'm not really sure what the oldest age would be or if there is like a cap on the age. I would ask Professor Seaman. I just know that it can go into the teen years, but I don't know if it's like based off of like some like certain like size the heart has to get to or what it is that finally like does it. So I would ask Dr. Seaman if there's like or Professor Seaman if there's like a cap on it. No problem. Wow, that is a lot of pages. Does it have like key points in the back at the end of the chapter? So I definitely minimally read the key points, especially before the lecture, if she's going over the lecture. That way you have like some idea. And then maybe reinforce lecture like or use, I don't know if you get the slides ahead of time, but if you get the slides ahead of time, maybe using that to guide like which sections of the book you read. Like if you know for sure she's going to go over a section because it's in the slide, definitely read that one. But if it's not in the slides, don't read it unless she goes over it in class, if that makes sense. No problem. Yeah, I would always want to get the slides in advance just so you could skim them ahead of class, because that's what they really have been pushing and recommending over the last year for nursing students. We've been harping on read before class or review your slides before you go into class. So when you're in class, it's not the first time seeing the material, and using class to kind of reinforce your own introduction that you do before class. It's actually a very, like, I was told, European style of teaching, but I cannot confirm nor deny if that's how they do it in Europe. Any other questions? Oh, okay, good. I'm glad you'll be able to watch it. Let me check. Hold on.
I wanted to spend just a tiny bit more time on the concept of shunting, just because it's
Okay, so I always recommend, I sent you the link, Khan Academy. Khan Academy does a great job of explaining like the physiological aspects. Oh, you're so welcome, of like everything. So this one is on the shunting of the heart. I think she has other videos that are like kind of lead up to this one, but this one she specifically wants to focus on like shunting. So that should help. And again, just Khan Academy, it got me through so many, all of patho, most of pharm, and it helped a lot with understanding just the physiological end of what's occurring in pediatrics, which helped to then like build it in my mind, if that makes sense. You too, stay safe.
You are currently the only person in this conference.